Thank you.
So Ivan asked me to talk a little bit about AFib ablation. So I'm one of the electrophysiologists at the Heart Center. I'll try to pace myself so we have some extra time to answer questions. So I think it's always good to talk about the ideal world because we have statistics, but they're all based on the type of selection of patients that were done in the original studies. So let's talk a little bit about the study patient. We could talk about the results for the typical study patient, which we can say is the ideal AFib patient. So we're talking about someone with paroxysmal AFib. They're mostly in sinus rhythm with very symptomatic episodes of AFib on and off. They tend to be young. They tend to be a normal BMI, normal left atrial size, no heart failure. And I'll just show, this is from the Fire and Ice trial that was recent. But basically, you could see, very common statistics for an AFib trial, age about 60, BMI 27. You can see the majority of the patients were less than 65 years old. And again, normal left atrial diameter, no heart failure. And this is the reason it was structured this way so that they can compare it to older trials and the results, because they don't want to have a trial that shows like, a low AFib freedom by including patients that are more persistent and have worse looking numbers than what was recorded in the past with the paroxysmal trials. And so this is what we typically see with AFib ablation. So we would expect, we'll talk a little bit about the blanking period, but we would expect over time, more and more patients to have recurrence of AFib. And this is after redos and touch-ups. And you can see by about a year, 35% of patients have had recurrence of AFib. And you can see over time, by about 3 years, it's about 50-50 that patients will have recurrence of AFib. This is a different trial. So that was just to show that AFib does recur. This ablation is not a cure for AFib. But this is a trial in terms of first-line therapy for AFib. And this is comparing cryoballoon ablation as a first line for paroxysmal AFib versus trying to manage it with antiarrhythmic therapy. And we could see that patients who are managed with AFib as rhythm controlled tend to do a little bit better, have less AFib than if we were trying to manage them for months on end with antiarrhythmic therapy. This kind of gives a more realistic expectation with the procedure. This is the same trial, but you could see, you have, these are all paroxysmal patients when they were enrolled, but on the antiarrhythmic therapy side, you could see one patient as an outlier who had persistent AFib on antiarrhythmic therapy. And when you compare it to the ablation arm, yes, there's still patients, probably diabetic, probably hypertensive, probably not the best substrate, maybe a little bit more obese. But, even the worst patient in the ablation arm, 30, 40% AFib of the time, some would say that's a failure, but if you were to compare it with antiarrhythmic therapy, you could see the dramatic reduction in AFib burden that AFib ablation provides. So the first thing we do when we talk to our patients and why we have the clinic is just to set realistic expectations. Unlike a lot of our ablation therapies for SVT and flutters, we emphasize to the patients that this is not curative. We do not expect to get rid of their AFib, but we expect that AFib ablation is excellent rhythm control. You could say even better than medical therapy, but you could say at least it's at least as good or better than medical therapy. And it provides additional control if they failed medical therapy. And now that we've been doing it for over 2 decades, we could say that AFib ablation is relatively safe, and I'll go over the possible complications in a bit. What we also stress is because we do get a lot of patients who think they can come off their anticoagulation. We say that, again, this does not change their stroke risk, even if they maintain sinus rhythm for the rest of their life. So I'll just show a little slide next. This is device data. It's hard to make sense, but the red line is when the patients had their stroke. And the dark black lines are where they had their AFib episodes and how much AFib they had during that day. So you could see it's highly uncorrelated. So for example, patient number 13, 15, 17, 19, you could say they were in sinus rhythm and free of AFib, yet they stroked. And then you could see, for example, patient number 10 literally had AFib for just a few days before their stroke. Some people, it's fairly random. So again, there's no temporal correlation between the actual stroke event and the AFib or the burden of AFib. So the current thought is that it's not the rhythm causing poor flow that causes the clots that then causes a stroke, and it's purely rhythm based. The current thought is that AFib is tied to an atrial myopathy, just like you would see LV thrombosis in the setting of an apical aneurysm. The rhythm could be normal, but the thrombus can form. The same thought goes for atrial arrhythmias, that it's the atrial myopathy itself, regardless of whether it's sinus or AFib rhythm, that causes the higher risk of stroke. And therefore, patients should remain on anticoagulation regardless of their rhythm at the time they're seen or how well they maintain sinus rhythm. So again, these are all possible complications. I'll go a little bit faster over these because I don't think there's a ton of interest. We'll highlight just the main things we tend to highlight with our patients, which is stroke risk during the procedure, which most people are worried about. We tend to quote a 1% risk of stroke, although we've done fairly well at our center, and I'd say we're less than 1%. Vascular complications are fairly high. It's reduced by ultrasound techniques, but it still often happens. We have heavier patients here when they weight bear, and sometimes they have growing puncture bleeds. This is the two techniques that are very popular these days. RF is predominant in the States, ICE predominant in Europe. In Canada, we're kind of split 50-50. So I'd say, at our center here at MB Heart, Dr. Toll and myself do ICE as the first therapy for first line. Dr. Fadden Hunsey goes RF. But like I showed in the earlier trial, equally effective, and it's just an operator preference. And this is what we see during the procedure. So this is a map of the left atrium. We could see in the upper map, it's a CT created map of the pulmonary veins. B would be us overlaying and then creating an internal map on the endocardial surface with mapping. And C is the result that we try to get. So we try to get electrical isolation of the veins. You can see that's in red where there's no electrical signals. Prior to ablation, you would typically see purple extending into the veins, and everyone has a different quote sleeve of muscle into their pulmonary veins, some extending far deep into the veins, some a little bit more proximal. But basically our goal is to get a wide antral isolation around all four veins. And this is what typical patient would experience here at the MB Heart. They're registered the day before the procedure. They have a TE to assess for a clot. Again, this is no longer standard. It used to be, but less and less centers are doing this on a high volume basis. PVI is done on day 0, and they are discharged home usually the next day. Again, some centers are moving towards a same day discharge for their first patient, usually the least complicated of the patients. And things to watch out for. So MSK pain usually would be concerning, especially if it's back pain, could be retroperitoneal hematoma. Chest pain, pericarditis, and pericardial effusion can happen, especially with our conscious sedation and sleep apnea patients. We can sometimes with RF perf through the up roof when they take a deep breath. So that's something we watch out for. We talked about cerebral events. We've had some kind of peri-op, also a patient who in the first week after the procedure, didn't take his anticoagulation, and had a transient event that was scary. Phrenic nerve injury I've circled just because numbers of phrenic nerve injury were higher in the first generation of the cryo balloons, as high as 15%. Nowadays, it's much less than 1% with the monitoring devices that we have. And the key is just to think, what do we do when the AFib recurs post-procedure? So I think it's good to talk about this. This is all in the 2017 HRS ablation guidelines for AFib. So these are all guidelines-based recommendations. So it's been noted in studies when recurrence happens in the first 3 months, and that's the typical blanking period used in studies that you saw earlier when I presented. They don't count recurrence of AFib in those first 3 months. And the reason why is about 50% of patients who have recurrence of arrhythmias in that first 3 months eventually settle and have no further arrhythmias. We've certainly had our experience with patients who called our office usually within a week after the procedure saying it failed having AFib. So we reschedule them and we bring them back, and takes with our wait list, it's like 2-3 months. And by the time we bring them back for a redo, they cancel because they're feeling great, they're asymptomatic, they've had no further episodes of AFib. So again, the mechanism is thought to be inflammatory with the healing. We're doing freezes or burns within the heart, causing a lot of inflammation. So it's recommended that we don't bring patients in right away after recurrence of atrial arrhythmias in the blanking period, because the majority of these patients often do just fine once the blanking period is over. Now, that's different in the 3-month to 1-year recurrence, which is called late recurrence. And it's felt that usually in this period, if there's recurrence, could be a reconnection in the pulmonary veins. I would say with better mapping, especially in the last decade or so, this is less and less common. But certainly, that would be something to think about, and that's the traditional thought. Usually on our redo procedures, we see maybe one vein reconnected with the RF. And with the ICE, it's highly variable. I've had my recent redos show no connections. So I think it depends on, operator, patient, and just knowing how the procedure was done and whether the veins are rechecked at the end of the procedure. In terms of very late occurrence over a year, we've also seen that patients who had excellent AFib results did well for 5-6 years. Some of them 10 years. For example, I had one come back who was done in Halifax almost a decade ago. When we see patients like this, we expect that there's a good chance that pulmonary veins may just be fine. They may have non-PV triggers. They may have bad substrate like an atrial myopathy. We usually check for reconnections because it's possible, but that's usually what we're thinking of when we see and triage patients with late recurrence or very late recurrence over a year. So when life is less ideal, and again, this is not a real person, it's a model actually that was done in the States for what a human might look like to survive a car accident. But I think it has a lot of features that would be concerning for poor restoration of sinus rhythm post-ablation. So a patient who would look like this would be high risk for sleep apnea, for pulmonary hypertension, for heart failure with preserved ejection fraction, would just probably be short of breath all the time, regardless of whether they're in sinus rhythm or not. So we have to take that with a little bit of a grain of salt. What kind of features may make AFib less effective? Certainly body weight. The heavier the BMI, you could look at the upper right corner, the less likely they're going to have sinus rhythm compared to a good BMI. And that's where we talk about the typical study patient versus real life. Bottom left, we talk about long-standing persistent versus paroxysmal. And again, paroxysmal does better, right? Blue, it makes sense. They've had less AFib, less atrial remodeling. So the chances of restoring sinus rhythm is much higher. Similar left atrial diameter, that's why I try to dictate it in my notes. I know by echo parameters, 40 doesn't seem much, 44 even doesn't seem much. We've certainly seen our fair shares of patients with a left atrial diameter of 60, even 90 millimeters. But what it does show is that the larger the left atrial diameter, the more atrial myopathy has already kind of developed, or atrial remodeling. And also the chances of restoring sinus rhythm for a prolonged period of time is less likely. This is an ongoing area of research, which is lifestyle modification. It's played a big factor. The Australians have looked into it heavily. Radhika Parkash is heading up the RASTA-AF trial, which is looking at AFib ablation versus AFib with lifestyle modifications to show that the addition of lifestyle modifications could have a big impact on control of AFib. And, you know, AFib ablation, you know, we give it a try because some patients say they're too short of breath, they can't exercise. So we hope for the best. Maybe AFib will give them some sinus rhythm and more energy. But the truth is, you know, weight loss, alcohol reduction, treatment of sleep apnea, increased physical exercise are all important in reduction of AFib. And we'll just show a little bit of a graph. For example, this is the weight loss graph. And basically it shows that if folks who are obese can lose some weight, they could have a dramatic impact on their AFib burden and AFib freedom. So if you looked at this graph, you would think this is an ablation graph, but actually this is just a weight loss graph for control of AFib. The other thing to note is that other atrial arrhythmias can occur post-ablation, and it may not be AFib. So these are some diagrams. You have typical, atypical flutters, atrial tachycardias. The flutters can occur in the left atrium or the right atrium using different circuits. And oftentimes what we end up doing is, if it is seen on ECG, and it's very important because the ECG gives us clues what we might be chasing, we might set up our procedure differently to specifically target that particular rhythm, rather than chasing the veins and seeing that the veins are just fine. So that's where ECG documentation of the atrial arrhythmia that they have post-ablation will help us figure out how we can help this patient in maintaining sinus rhythm. The other thing just to think about, catheter ablation in asymptomatic persistent AFib, probably the least recommended kind of ablation patient. And that's because you can turn an asymptomatic AFib patient into someone who is now symptomatic if they have other atrial arrhythmias like flutters or atrial tacks after the procedure. So we always talk when we're referred because a patient has an asymptomatic AFib, you know, just explain that there's a chance that they could feel worse if they were to have a different arrhythmia other than AFib after their AFib ablation, and that this is unpredictable. The benefits is that a lot of patients do feel better after their ablation. So that's and we'll talk a little bit about that as well. And then there is such a thing as too much ablation, because really, what's the way to cure AFib? It's just to ablate the whole atrium, right? The whole atrium can be a substrate of AFib. But if you do ablate the whole atrium, and we have historically done more and more ablation. For example, you have a patient who had the vein isolated with recurrence. Centers in the States and a few other centers in the world have done posterior wall ablations. So you carpet bomb the entire posterior wall of left atrium. Then you're doing roofs and then lateral lines, and then you ablate more of the lateral and more of the roof, and then you're chasing triggers in the right atrium. And you eventually end up with this, the stiff left atrium syndrome. You can see the dramatic pressure tracing before ablation, after. You can imagine how much that dramatic change in wedge pressure would affect someone's quality of life and shortness of breath. So again, something we're trying to avoid. Some of the Canadian trials, like Atul Verma doing his STORY-F, has showed that our thought in the past of more is better may not be right. He's certainly shown that more lines make a higher potential for more atrial arrhythmias. So we've been more cautious, sticking more to pulmonary veins. And whenever a good technique comes up, we try to add it to our mix. We're trialing different things like vein isolation of the ligament of Marshall. So there's other things going on, but we're just waiting for kind of more consensus among the EP community. Again, issues with more ablation, substrates, pulmonary hypertension. Again, very common in our New Brunswick population: diabetes, sleep apnea, left atrial size, left atrial pressure, severe scarring in some, all contribute to kind of poor results, poor satisfaction post ablation. And we just have to be realistic. The left atrium is more complex than we realize. We think of it as a uniform piece of muscle. It's a small, thin structure, we think. But the truth is, there's multiple overlapping bundles oriented in different directions. For example, the Bachman bundle across the roof, septopulmonary bundle across the back and the right, near the right pulmonary veins, the ligament of Marshall. So it doesn't behave the way we expect if it was just a simple myocardial muddle. We also have to understand that we don't quite understand what happens, what keeps patients in AFib. We used to think there was a component of the ganglionated plexi, which are kind of sympathetic nerves, and that ablating them could help. That's in picture A. We've looked at rotors, rotating focuses. In B, we've looked at triggers, which can be from the pulmonary vein or within the heart in C, or it could be a combination of all three mechanisms, right? Our ablation lesion sets try to cover as many of these mechanisms as possible. When we do a wide antral, we do cover a lot of the ganglionated plexi as well as triggers. But there's a lot of areas we don't cover, and that's intentional. Like I said, we can't ablate everything. If we do, it's also a danger to the patient. So we try to ablate what needs to be ablated. And I was just in the States, and a colleague of mine down in Boston was talking about how he does this convergence procedure, which is a pericardial approach with surgical help. And he's seen a few patients where the endocardium is completely isolated, but somehow the epicardium is very active and in AFib. So again, we don't completely understand the left atrial, you could say, anatomy, physiology. AFib is quite complex, but that's why it's still an ongoing area of research. We've been looking into it for 3 decades. We've gotten better, but we're still not at the point where we can cure AFib. And this is the indications for AFib ablation. So definitely, trial of antiarrhythmic drugs would be a class 1, and failure of an antiarrhythmic drug going on to catheter ablation would be a class 1 indication for ablation. Every other indication is class 2A, meaning either direct to catheter ablation. Long-standing persistent AFib, again, these are patients who have an AFib over a year. 2B, so we're realistic with our patients, telling them that, trials don't really support a good result with these. And we also just give them a realistic expectation that the goal may not be obtaining sinus rhythm, but it may be to reduce heart failure symptoms before we trial the ablation. And just for the persistent AFib population, a lot of the trials enroll patients with AFib and call them persistent, even though their AFib duration may have been less than 3 months. So just these would typically be considered early persistent AFibs. But, you know, it is a 2A indication for the, you could say, the early persistent AFib population. And I'll stop here in case there's questions for me.
Thank you, Dr. Wang, for an excellent presentation. I have a quick question. In UK, I was involved in these hybrid procedures on the surgical side. Do you see them coming anytime soon in our center?
Yeah, it's a good thing to discuss. I mean, we would obviously need very close surgical support for this. Seems to be the person who does it a lot in Boston has published trials. Obviously, he's very positive about it, and he thinks it's a great procedure to do. So, you know, I would be interested in exploring it. But we'll see what the buy-in is, maybe something to discuss, because it would be a multidisciplinary kind of team approach, much like the TAVI approach, right?
Yes, correct. Thank you. Okay, any other questions? Please chime in or raise hand or text in the chat.
I think Dr. Kamel has his hand raised.
Oh, great. Hi, thanks, Sam. That was fantastic. I was wondering if you could make some comments about tachycardia-induced cardiomyopathies, and when you would say, okay, even with rate control, maybe we should try to get them back into sinus rhythm with ablation, and then your kind of quick thoughts on when it's indicated in heart failure patients, because I know that's kind of another topic on its own.
Yeah, so I'll say this: it's tricky, right? The classic tachycardia-induced cardiomyopathy, where they drop their EF, but then with good rate control, their EF goes back up. I'd say they're excellent candidates for AFib ablation. We tend to prioritize these patients, and that's with documented recovery of EF with rate control. Oftentimes, we actually get referred patients who just have heart failure and low EF with no recovery, and that is less clear if it's tachycardia-induced or not. So those patients are a little bit trickier, but based on the CASTLE-AF trial, we have been ablating even the persistence with heart failure to give them a trial. And my experience is it helps with the heart failure, even though it may not get rid of their AFib. So one patient that I know in particular that was recently referred for a redo, her tachycardia-induced cardiomyopathy she had complete improvement, restoration of normal systolic function. Post-ablation, still feels fatigued, but she's obese. She's in persistent AFib. Rate is much better controlled. And the question is just redo, right? And I would call this a success because, again, we're not looking at restoration of sinus rhythm in this long-standing persistent AFib population, but we do have data showing that we get better heart rate control. So it's almost like a digoxin or a metoprolol on top of their regimen to give them additional rate control. And that's what the CASTLE-AF trial showed, that we get better rate control and less heart failure, even though AFib still continues.
So just to follow up, how do you identify which patients from like CASTLE-AF? Because I mean, I could think of hundreds of people with like ischemic cardiomyopathies that develop atrial fibrillation, and now their EF's a little bit lower. Which ones do you do? Because I mean, it seems to me that they've got a low success rate. How do you pick those patients, or how do we pick those patients to refer?
We haven't been as picky. I mean, like certainly if we have, like, let's say someone has a really bad substrate, right? Like, for example, recently I did I got a lady with severe hypertrophic cardiomyopathy, left atrium 6 by 9 centimeters, extremely enlarged. It's the cardiomyopathy itself. It's not tachycardia induced. Like their AFib is a result of their cardiomyopathy and not the other way around. We've still given it a try to give them an AFib ablation. I find it's very hard because some patients surprise you. We have this patient with a huge left atrium. She came in paroxysmal on amiodarone. And I certainly see younger patients who are persistent with less of this myopathy. So it's always tricky. Who do we choose? Who do we bring in? We tend to have an internal discussion within our team. We discuss with our patients. Some, when they hear that they're not going to be able to get off their anticoagulation and it's purely for quality of life, and we don't know, certainly they're still going to have some shortness of breath with their low EF from their ischemic substrate. A lot of them will just say, well, we feel just fine. But there's also a lot that would say, well, I'd just like a try and see how it goes. So those are the type of patients where I typically might try a one-off ablation just to see how they do. If they still don't feel any better, I would say, well, we wouldn't bring them back because they've obviously shown that their symptoms are not necessarily all AFib related. And it probably doesn't help to bring them, back for a complicated procedure with, we most likely the 4 veins are isolated or they're just a small gap on one of the veins. They're probably not going to have as dramatic of effect on the second go around. So I try to just, so I think a lot of that comes into our discussion. So we get a lot of referrals, Sharif. And if you have any questions and you think the patient is a good candidate for ablation, just send it to us and we'll usually address that in our clinic with the patient.
Great, thank you.
Okay, thank you for your questions. I think we ran out of time. Thank you again, everyone, for joining us today. Dr. Wang, thank you for a great presentation. And I will see you next week. Thank you.